Thank you, Michael, for a very kind introduction. May I have slides, please? I would like, in the meantime, to thank the organizers of this meeting for inviting me. And this is the first World Conference on Poseidon, and I find very stimulating and very interesting. So today I've been invited to talk about female age, oocyte, and embryo competence, the relevance for Poseidon criteria. This is the disclosure of my conflict of interest. May I have another changer? And this is a paper that we published a couple of years ago. It's an important paper we published on Science. Well, the first time we showed that the proportion of aneuploid metaphase 2 oocyte is lower between 20 and 32, and therefore is maximal between the same age, as you can see from the right curve, and these corresponds to the maximal fertility period of the woman. On the other, sorry, may I have another changer because it doesn't work properly. On, grazie. Okay, so similarly, there's a dramatic increase of the miscarriage rate with the increase of the age because there's a decrease of the euploid competent oocyte that makes euploid and competent blastocyst. And as it was already mentioned, and then we focus on these, and the focus of Poseidon is, in fact, the number of the oocyte to obtain an euploid blastocyst. So the importance of the oocyte with the age is represented in this slide. And then you can see that in women lower than 35, you too obtained to have good chance to obtain a euploid blastocyst, you could need about 4 metaphase 2 oocyte, 35, 37, 5 to 7 oocytes, and then once you go to for more than 42, 20 oocytes, and on 43, 44, you need 30 metaphase 2 oocytes. At 43, the euploidy rate of the embryos and therefore the oocytes is about 10%. If we consider, like I firmly believe, but also the ESHRE guidelines is reported like this, that the measure of success in IVF is the efficacy in terms of cumulative live birth rate per started cycle, and not in a 18 months period. So the cumulative live birth rate per started cycle. Then the most important factor that affects the cumulative live birth rate, of course, is the number of the oocyte and the age of the patients. But first, is important to think about the safety for the patients, namely concerning the risk of ovarian hyperstimulation syndrome and the multiple pregnancy rate, which are the two most important complications in assisted reproductive techniques. And in patients at risk of ovarian hyperstimulation, it should be mandatory. It should be mandatory to use a GnRH antagonist protocol with the agonist trigger and the freeze-all strategy. And to reduce the risk of multiple pregnancies, it should be strongly recommended. Of course, it should not be considered mandatory, but strongly recommended, the single blastocyst transfer, trying to select the blastocyst the high chance to implant, either by using the time-lapse and or the PGTA, and possibly soon the non-invasive PGTA, and everything with the valuable help of artificial intelligence. And the cumulative live birth rate continues to increase with the number of the oocyte retrieved. And then from 2011, from the paper published by Sesh Sankara in Human Reproduction, till today, several papers have been published showing exactly this. I just present here one of the most cited paper, which is that one of Nikos Politsos on almost 1,500 patients. Then you can see that looking at the blue bars, that the cumulative live birth rate continues to increase with the increase of the number of the oocyte. But so we should try to optimize the oocyte number, to maximize the cumulative live birth rate, but two important issues have to be, I don't know where to, two important issues have to be considered. So the first one, what about the embryo competence? And the second one, does the optimization of the oocyte number per ovarian cycle improves the efficacy of the treatment in poor prognosis patients? With regard to the first question, you have for sure heard many times the tale that says that if you retrieve too many oocytes, the competence of those oocytes would be worse than retrieving few oocytes. And this is absolutely not true. Several papers demonstrate this. And this is one paper from Elena Labarta from the EV group of Valencia, and that shows that in a good prognosis patients, the donors, shows that if you increase, if you increase the number of oocyte retrieved, it will significantly increase the number of euploid embryos. And if you look at the euploidy rate remains constant across the number of the oocyte that you retrieve. So if you retrieve 10 oocytes in this good prognosis patients, it will be 60%, 20, 60%, and 40, 60%. We have been published in 2015 similar results, and many other papers show this. And also the euploidy rate is independent from the gonadotrophin dose used. So also the tale that says if you use less amount of gonadotrophins, then you will have better oocyte quality is not true. And this is one of the papers published more recently in Human Reproduction, showing that if you, either you use 3,000, 3,000, 5,000, or more than 5,000 international units, the euploidy rate is comparable, but it decreases only with the increase of the age of the woman. So therefore, the more oocyte we retrieve, the higher is the chance to find at least one euploid blastocyst, as is demonstrated in this table that has been published in 30 study in 2018 in a paper that celebrated the 40 years of assisted reproductive. This is the frequency of chromosome anomalies in human blastocysts that have been analyzed with NGS in more than 100,000 embryos. And then you can see that if you increase the number of the embryos obtained, so therefore the numbers of oocytes, you will increase the chance to find at least one euploid blastocyst. And this is particularly true, of course, with the increase of the age of the women. So the second one is, does the optimization of the oocyte number per ovarian cycle improves the efficacy of the treatment in poor prognosis patient? And this we have to clarify first, who is a poor prognosis patient? The poor prognosis patient is a poor responder that for different reasons respond poorly to controlled ovarian stimulation, and therefore she will have a reduced number of oocytes, reduced number of embryos, and reduced chance to have a live birth. But a poor prognosis patient is also a patient with an advanced maternal age patient, often also poor responder, that has a higher rate of aneuploid oocyte, higher rate of aneuploid embryos, and therefore reduced chance of a live birth. The key issues that deals with this group of patients are that they have very low success rate with standard, mild, natural IVF, whatever you do with these patients, they have a reduced success rate compared to the good prognosis patients. They have a reduced time available to try to conceive, so we must try to use treatments that aim to shorten the time to pregnancies for these patients. And these patients have a high incidence of dropout, they are very discouraged, they are tired, they think this is my last time, and when it fails, this is, they drop out, and then they quit, they stop their chance to have a live birth. So the best way to classify the poor prognosis patients is the POSEIDON criteria. I will not go through because already Carlo and Robert have extensively discussed. But if I can manage the try to manage the poor prognosis in group 1 and 2 by increasing the dose of gonotrophins and adding LH, what about what I can do to improve the number of the oocyte retrieved in group 3 and 4? I remember that group 3 and 4 are those patients younger or older than 35 that have a very poor ovarian reserve. And in this group of patients, if we increase the dose of gonotrophins, this will never compensate with the absence of follicles. And even if we use a more powerful drug, this is also will not compensate that. In fact, gonotrophins can only support the course of follicles. They cannot make follicles de novo. They cannot manufacture follicles de novo. And the ESHRE guidelines suggest that you cannot use more than 300 international units of gonotrophins because it's completely useless. So what to do in these patients? Can we apply the non-conventional stimulation to try to optimize the oocyte number in poor prognosis patients? Yes, we can try, and we can try to modify the paradigm. It's not anymore the critical outcome for IVF is the efficacy in terms of cumulative live birth rate per started cycle, but it could be the critical outcome for IVF is the efficacy in terms of cumulative live birth rate per ovarian cycle. So per ovarian cycle, let's see whether we can increase the number of the oocyte that in this difficult group of patients. So there are a couple of most accredited theory on folliculogenesis. The wave theory, where there are 2 or 3 cohorts of follicles that are recruited per ovarian cycle, and the most accredited is the continuous recruitment theory, where follicles starts growing and regress continuously during the ovarian cycle. We don't know exactly which is the mechanism of regulated folliculogenesis, but thanks to the dynamics of folliculogenesis, we could introduce new stimulation approach. They changed our paradigm, and we can maximize the oocyte yield per ovarian cycle with this dual stim strategy. And this is the original paper that we published in 2016. It was a pilot study with only 51 patients. And due to reduced number of patients, our main outcome was to demonstrate that the competence of the oocyte retrieved during the second stimulation was as good as the competence of the oocyte retrieved after the first stimulation. This is the original scheme of the dual stim. You can see there are 2 conventional GnRH antagonist protocol with high dose of gonotrophins that are repeated back to back after 5 days, starting the second one 5 days after the oocyte retrieval. So this is a few years later, we published this first paper on human reproduction with 170 patients that completed the first and the second stimulation, and we started to see some differences between the first and the second stimulation. The metaphase 2 oocyte retrieve was significantly higher in the second stimulation. The number of blastocysts was significantly higher because the number of the oocyte was significantly higher, and the fertilization and cleavage rate was comparable. And the euploid blastocyst, the number of euploid blastocysts was significantly higher because the euploid rate was at least comparable between the oocyte from the first and the second stimulation. And when we transfer the single euploid blastocyst coming from the first on the second stimulation, then the live birth rate was absolutely comparable. Then we published the first multi-center study, and this study confirmed the results that I just shown you. And what it was clinical relevant is that with the dual stimulation in the same menstrual cycle, you increase the chance to find at least one euploid blastocyst compared to a standard stimulation, is 65% versus 42%. But I think at the beginning I said that it's very important to try to reduce the dropout, especially in this group of patients. And this is a paper that we published a couple of years ago in Fertile Sterile in a very difficult population of patients. They are Poseidon 3 and 4 or Bologna criteria. And then you can see that if we compare the two conventional stimulation versus the duostim, of course, the dropout rate was 0 with the duostim, and with the two conventional stimulation, those patients that failed the first treatment, only 10% did the second approach. So at least in our setting, and this is a private setting, the dropout is very high. And look at the number of days between the first and the second oocyte retrieval, 15 days with the duostim and 141 days with the two conventional stimulation. And when we look at the live birth rate per intention to treat, it was 15% in the duostim and 8% in the dual stimulation. But when you introduce a new technique, when you introduce a new strategy, you have to, take care first to the health of the babies born. And this is the first paper that we published on human reproduction on the obstetrical and perinatal outcome after the use of blastocysts coming from the follicular phase of the luteal phase. No clinical differences between the two. And when we look at the birth rate or gestational week, there were absolutely no differences between babies born from euploid blastocysts coming from the follicular phase of the luteal phase. And these were almost 400 blastocysts transferred. But this is an important issue regarding the time to pregnancy. This was the first prospective randomized trial that was published, that was presented last year, so in 2021, at the ESHRE by the group of Juancho Velasco, and comparing the two strategies. And you can see that the days to obtain an euploid blastocyst was significantly lower if you do the duostim compared to the conventional stimulation. But this year, two papers did not agree with this strategy. And this is a paper, a prospective randomized trial that has been presented at the ESHRE this year from the group of Herman Tourné. You see the randomization regarding 24 patients in the control group and in the study group. And so it was compared the duostim versus one conventional stimulation. And there were no differences in terms of number of oocyte, number of metaphase to oocyte, good quality embryos. And they compared the first stimulation with the duostim with the conventional stimulation, and they found significantly reduced number of oocyte retrieved, metaphase 2, and good embryos. And they said that this was due to the agonist trigger. But we use almost in all cycles the agonist trigger, and we do not see these differences. But when the embryos obtained from the dual stimulation versus the conventional stimulation, then you can see that they obtained a better outcome with the embryos coming from the dual stimulation. And they claim that in poor responders, the freeze-all approach could determine better results. So the other one is the paper by Massine, Aurora representation. And again, this is a small prospective randomized trial. 40 patients were randomized in each group. They reported a shorter time to obtain the second oocyte retrieval in the duostim, but the oocytes and number of oocyte and metaphase to oocyte were comparable, and also the embryo transfer and the embryo transfer fresh and frozen were better in conventional versus duostim. But what are the pitfalls of this study? First, that they cryopreserve the oocyte and not the embryos. And even in the best cryopreservation program, the survival rate of the oocyte, of the frozen oocyte, is not comparable to the blastocyst vitrification. And so at least 20% will not survive to the thawing. And the trigger was performed with ACG, and if you trigger with ACG, you will have the corporal lutea that will last for several days, and then the second stimulation will be not optimal like the first one. And the third oral presentation that was in favor was in a Spanish group, and from the Raquena group, and then they supported the use of the dual stimulation, especially because you can achieve more oocytes in especially efficient in patients with good high response, and could be beneficial in social preservation and in the donors. So now I'm going to show you our data that have not yet been published, that I ask to prepare from when we started to do routinely dual stimulation, so from 2016 to 2022, and then you see that the maternal age is 40. So we are dealing with patients of 40 years old as a mean. And the main cause of infertility, the sperm factor, and the patients that stopped during the second stimulation in the second ovarian cycle was 7.5%, and the days between first and oocyte retrieval was 18.6 days. And this data regards almost 1,900 dual stim cycle. So the mean number, this data confirmed the data that we published earlier in a smaller number of patients, and the mean number of metaphase 2 oocyte retrieved in the second stimulation is significantly higher. The mean metaphase 2 oocyte per oocyte retrieved is significantly higher in the second stimulation. The mean 2PNs, since the fertilization rate is the same, is significantly higher, as well as the mean blastocyst, as mean as the euploid blastocyst, because the cleavage rate, the fertilization rate, the cleavage rate, and euploidy rate is exactly the same. So we confirmed this data from the previous publication, and I think that this is a very huge amount of data to confirm this. And what about the clinical outcome? So when we transferred the blastocyst coming from the single euploid blastocyst coming from the first or the second stimulation, you can see that there are absolutely no differences in terms of positive pregnancy rate, biochemical, miscarriage, and live birth rate. And look at here in the box what is clinically important, that in a patient population of 40 years of age, we can obtain with a dual stimulation in 25% of patients at least one live birth, and several patients have more than one euploid blastocyst and have more than one live birth. So, but what about if we changed the paradigm in normal responders? Why only in poor responders? And the critical outcome for IVF is also in normal responder in terms of cumulative live birth rate per ovarian cycle. Who is a normal responder? We know who is a normal responder. And the consideration for these patients that we have to have very clear in our mind is that 80% of our patients are more than 35. Oocytes with higher meiotic aneuploidy rate, this group of patients, between 50 and 90% according to their age. They have less time available for conception, so we should try to shorten the time to live birth. And most of them, they prefer to do one and done strategy. And with regard to the aneuploidy rates, we have already seen this data, but we have to have very clear in our mind this, because when we consider which is the prognosis of these patients, we have to know that at 35, 50% of the blastocysts are euploid. Either you test or you don't test. 38 years of age, between 30 and 40%, at 40 between 20 and 30, at 43 between 10 and 20%. And also different is the cleavage rate. to the blastocyst, the blastulation rate. And the mean blastulation rate is between 30 and 40%, but there are in some patients that the blastulation rate is much lower, especially in patients with a severe male factor infertility. And then we published this 4 years ago in Fertile Sterile. So let's think about these 3 examples. We have a woman of 35, a woman of 38, and a woman of 42. They retrieve 8, 10, and 12 oocytes, so classified as normal responders. The 35 has 2 blastocysts, the 38 has 3 blastocysts, and the 42 has 3 blastocysts. The euploidy rate, even if you test or you don't test, is 50%. So in the first, you don't, in the 35, in this group, in these patients, you don't have to do a duostim. Similarly, in 38 is 30%. You have 3 blastocysts, no duostim. 42, 10 to 20%, and even if you retrieve 12 oocytes, she has 3 blastocysts. The chance to find euploid blastocyst is very low, so you repeat another stimulation in the same ovarian cycle. And similarly, I have no time, these are other 3 examples, but say exactly the same thing. Look at this one, very young woman, 12 oocytes, very good ovarian response, but because she has an husband with testicular sperm, she will end up with 1 blastocyst. And in these patients, even if she had 12 oocytes, then it's worth it to do the dual stimulation. So let me conclude saying that the cumulative live birth rate per started cycle, it should be considered a measure of success in IVF, and the oocyte number and the age of the patients are of utmost importance. We must try to maximize the oocyte number with the right drug and with the right control variant strategy. First, safety for the patients. We have to reduce the risk of ovarian hyperstimulation syndrome by using generation antagonist protocol and agonist trigger and freeze-all strategy, and reduce the multiple pregnancies by transferring 1 single blastocyst. We could change the paradigm from cumulative live birth rate per started cycle to per ovarian cycle, as we did already in the poor responders with the duostim. And the duostim strategies reduce the time to find an euploid blastocyst, prospective randomized trial, reduce the dropout rate, the paper that I show you, and another one that has been already published, just published in JARG, that's showing with a bigger amount of patients exactly the same results, and no differences in obstetric and perinatal outcome. We could change the paradigm also in normal responders. The blastulation rate could be different among different couples, and it can be influenced by the age of the patients, by the male factor. So we could personalize the control of ovarian stimulation, decide if to apply the dual-stim strategy, starting the second stimulation according to the number of the blastocysts obtained after follicular phase stimulation and the age of the patients. This personalization could maximize the cumulative live birth rate per ovarian cycle, also in normal responder patients. Thank you for your attention. I apologize for the delay.